Welcome back, everyone, to part 12 of our Masterclass Explainer series. Today, we're tackling one of the most highly scrutinized, frequently audited, and honestly clinically complex areas in medical coding. We are talking about the progressive severity of sepsis coding. We're going to break down the ICD-10-CM coding guidelines for sepsis, severe sepsis, and septic shock. Whether you're a seasoned coder or a CDI specialist, getting this right is absolutely crucial for clinical accuracy and revenue integrity. Here's our roadmap for today. We'll follow a hierarchical progression that mirrors a patient's clinical deterioration. First, demystifying sepsis coding rules. Second, coding basic systemic infections. Third, severe sepsis linkage rules. Fourth, septic shock sequencing guidelines. And finally, defending against payer audits. Okay, let's dive right into this by challenging a common clinical misconception right out of the gate. Can you actually code sepsis when the patient's blood cultures come back totally negative? It's a scenario we see all the time, right? And it almost always causes a bit of hesitation. Keep that question in the back of your mind as we start laying the groundwork. Section 1. Demystifying sepsis coding rules. Coding basic systemic infections. So to answer our question, we first need to set the baseline rules for capturing that underlying systemic infection. When you're diagnosing and coding sepsis, you always want to aim for the correct code for the specific underlying systemic infection first. Is it streptococcal, gram-negative, staphylococcal? The specific pathogen really matters. But let's be real, clinical documentation isn't always perfect. If the infection type or the causal organism is completely left out of the record, well, that's when you assign code A41.9 for sepsis unspecified organism. It's your default when the specific pathogen remains a mystery in the provider's notes. Now back to our hook question. The answer is a definitive, absolute yes. Sepsis can absolutely still be diagnosed and coded based on clinical evidence, even if those blood cultures are negative or unclear. Your code assignment is based on the documentation by the physician, not just a single lab result. As CMS makes very clear, clinical evidence should be present in the medical record to support the code assignment. So if the clinical indicators are practically screaming sepsis, but the cultures are negative, you rely on the provider's clinical validation. And of course, if there's ever any doubt, always confirm with the provider. Section 2, Severe Sepsis Linkage Rules, subcategory R65.20. As the patient's condition worsens, we step up the clinical hierarchy to severe sepsis, bringing us to the highly scrutinized critical causality rule. This is where we really need to lay down the rule of law. Severe sepsis is defined as sepsis with associated acute organ dysfunction or multiple organ dysfunction. But here is the massive catch. You must never assign a code from subcategory R65.20- if the acute organ dysfunction is caused by another, completely unrelated medical condition. For example, if a patient has sepsis, but their acute kidney injury is clearly documented as being caused by a totally different issue, you literally cannot code severe sepsis. To assign R65.20, the acute organ dysfunction must be explicitly linked to the sepsis itself. The provider has to clearly document severe sepsis or explicitly state the organ failure is actually due to the sepsis. It has to be sepsis with organ dysfunction, not just sepsis and organ dysfunction. Because this linkage rule is so incredibly strict, we have to be extremely vigilant. If a practitioner's documentation is even slightly ambiguous regarding this linkage, a physician query is absolutely mandatory. You have to query the provider if it's unclear whether the organ dysfunction is actually due to the sepsis or some other condition. You also need to query if the source of the infection is nowhere to be found, or if there's any ambiguous documentation regarding the actual presence of sepsis or septic shock when the clinical indicators are all there. Bottom line, don't guess, query. Section 3. Septic shock sequencing guidelines, R65.21 and T81.12. If severe sepsis is left unchecked, we unfortunately reach the most critical state. Let's make sure we're on the same page with the definition. Septic shock generally refers to circulatory failure associated with severe sepsis. So by definition, it represents a specific type of acute organ dysfunction. You literally cannot have septic shock without inherently having severe sepsis. They're fundamentally tied together in both the clinical and coding worlds. Now, what's really interesting about this is the mandatory sequencing. The tabular list gives us very strict, rigid orders that you just cannot ignore. Step 1, you must sequence the code for the underlying systemic infection first. Step 2, follow that immediately with code R65.21 for severe sepsis with septic shock, Or, if it applies, code T81.12 for post-procedural septic shock. And step 3, actually, scratch that, a lot of people miss this one, you are not done yet. You must assign mandatory additional codes for all other associated acute organ dysfunctions the patient is experiencing. It's a chain of codes that tells the complete, specific story of the patient's critical state. And hey, if you take absolutely nothing else away from today's sequencing rules, please memorize this. Code R65.21 can never be assigned as the principal diagnosis, ever. The underlying systemic infection has to take that primary spot. Dropping R65.21 as the principal diagnosis is a direct violation of the tabular list sequencing instructions, and I guarantee it will result in immediate issues with your claim. Section 4, Defending Against Payer Audits, Protecting the Claim. Because let's face it, if you code sepsis, you will be audited. So let's shift to the real-world application. This guideline brilliantly illustrates your ultimate shield against auditor denials. It's a direct quote from the ICD-10-CM official guidelines for coding and reporting, section I.A.19. It explicitly states that the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. Code assignment is not based on clinical criteria used by the provider to establish the diagnosis. This completely empowers you. It proves that the physician's clear diagnostic statement legally trumps an auditor's retrospective clinical criteria review. But you still need to know exactly how they're going to attack the claim, right? Medicare Advantage and commercial auditors frequently deny severe sepsis claims for a few very predictable reasons. First off, they are always looking for that missing explicit physician linkage between the infection and the organ dysfunction. If it's missing, they deny it. Second, many auditors have adopted the Sepsis 3 criteria, but are, shocker I know, magically modifying the organ dysfunction criteria to be overly stringent without any real clinical basis other than to deny your claim. And finally, they often try to argue that the organ dysfunction was caused solely by a localized infection, rather than the systemic sepsis. This is exactly why airtight documentation and explicit provider linkage are your absolute best defense. We've covered a ton of ground today, from basic systemic infections all the way through the critical nuances of shock and audit defense. So ask yourself, is your current clinical documentation bulletproof enough to withstand the scrutiny of tomorrow's audit? Stay tuned for part 13, where we explore sequencing complexities, breaking down sepsis versus localized infections and non-infectious conditions. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.